Okay, so I'm Cassandra Heiselman. I'm one of the maternal fetal medicine physicians over at UC Stony Brook with Petter, but now over at the Cleveland Clinic Foundation. So my talk is just kind of on pH in general, finding the ground truth. But I will say and preface this, I'm not an expert in pHs in any capacity, but just wanted to kind of have this talk to kind of inspire some conversation and some thought process about using pH as an outcome and what it can and cannot tell us. So just kind of going into normal values and outcomes, as most of us know, the mean umbilical artery pH at term, depending on what article that you use or what reference you use, may be somewhere around like 7.11 with ranges in that kind of space. There was one article that talked about the ideal cord pH associated with the lowest adverse neurologic outcomes is somewhere around 7.26 to 7.30. There was a very lovely large Danish national cohort of over 340,000 fetuses that looked at different pH ranges and kind of composite outcomes for things that we would care about. So their composite outcome was death, therapeutic hypothermia, mechanical ventilation, seizures, and the need for other things. And that in their baseline reference group, which was at 0.7 to 7.5, was basically 0.2%. We then, they looked at neonatal death in that time period, hypoglycemia, and some other things that I'm not going to get into because that's not what this talk is about, but just kind of showing the different short-term outcomes with the associated pHs. You can kind of see below 7.0, that composite outcome was 9.8% in that cohort and got substantially less and less as we kind of got into higher pHs. So the composite outcome in that second box was 0.8, then 0.4, and then 0.2, like I said in the reference. So truly a significant change when you're under that 7.00 cutoff. Then as far as long-term outcomes, there's many different outcomes you can look at, but things that we have associated things with are basically going to be like cerebral palsy, epilepsy, HIE with seizures, which is the more kind of severe form, and or death. So kind of different cohorts here looking at the different cutoffs of, again, pH and what that increased risk is. So just kind of talk in general senses. So what does umbilical cord pH actually reflect? So it's basically a proxy for the level of fetal oxygenation and this biomarker basically for intrapartum fetal hypoxia. So I took this very lovely figure from, I'm not going to try to say names, but from the articles that was published in 2023 that did obviously some pig models for this, but just kind of looking into normal birth basically involves this transient kind of drop in oxygen to the baby. That is normal process of contractions. This intermittent hypoxia is usually well tolerated by a well-compensated fetus where they have physiologic mechanisms that make it okay to deal with the stress of that. However, when O2 deprivation is prolonged, that's when you start getting abnormal kind of uteroplacental gas exchange. This kind of anaerobic metabolism ensues, which then makes more of the lovely H's that then results in metabolic acidosis. You also have hypoxemia and then hypercarbia as well. So this kind of, the beginning part is kind of normal stuff, but then when you really do prolonged stuff, that's when you start really getting reduced, like I said, viability at birth. So, but pH is also influenced by various factors, kind of like when other talks talked about the different factors that influence just even neurologic injury and HIE and poor outcomes for babies. Same thing of like what is influencing pH in itself, not just the kind of low oxygen deprivation. So mode of delivery actually can affect it, regional anesthesia, cord variations like true knots and things. There's not enough data out there to truly say, but it's theorized that it potentially could. I did put up here some intrapartum events and then kind of medical comorbidities. So the kind of top part is looking at like mode of delivery. So elective cesareans without any labor have pHs that are similar to kind of adult values. The one study said the median was 7.29. Vaginal non-instrumental ones were a little bit lower. Further than that is going to be assisted vaginal, so forceps or vacuum, and then even further than that, immediate cesareans or emergency ones that were unplanned during the labor process. Epidurals actually are protective. they found that potentially decreasing or modulating the cytokines with pain and that kind of pain experience may do that, but the understanding of why physiologically, not as much. Duration of the second stage is actually pretty interesting. So the longer and longer a woman pushes, the lower and lower, the associated pH potentially. And then also maternal conditions. So preeclampsia, diabetes, especially pre-existing diabetes and poorly controlled, also lowers the pH. With diabetes specifically, the conversation is actually those fetuses may be more vulnerable to the stress of that normal physiologic oxygen deprivation. So they have more rapid declines in fetal pH during periods of stress. And then also clinical choroidinitis, which I know already went into as well. So cord pH is everywhere and why we should be cautious. So this is the most widely used intrapartum biomarker for fetal well-being. And yet there's a lot, and I kind of group them into 3 different spaces, but issues that come into pH in general. So you have your pre-analytical errors, so sampling delays, when did we actually get these, vessel misidentification, the variability in just actually the machine itself. Interpretive ambiguity, so differentiating between respiratory versus metabolic acidosis, gestational age effect, so gestational age at which you are sampling is going to affect the pH, and then there's no actual consensus on predictive thresholds. Go back to my other slides in the beginning with all the different thresholds that people use to predict poor outcomes. And then also, we'll get into this in much more detail, weak predictive values. So is this actually telling us what we want it to? So again, going into more detail for things. So here's our lovely cord segment, having to both identify the cord, but something that's actually interesting that's coming up more and more is delayed cord clamping. So this is now something that the WHO and the United States, all of our organizations are really pushing for delayed cord clamping for at least 60 seconds, sometimes up to, 3 minutes or when the cord stops pulsing. This is going to very much affect the sample that you have. As far as what this is actually showing from a sample to the actual baby. Within seconds of birth, acidic metabolites from peripheral tissues kind of flood the central circulation as the newborn transitions from fetal circulation to being out in the open, circulation, newborn breathes and cries. So it can actually falsely give you acidic values, and that is even more as things get delayed. And then also, not everyone is getting that cord pH right away too. Sometimes that sample of the cord is cut like that, it's put down on, a table. People aren't getting to it until 20, 30, 40 minutes later, potentially. And that is not reflected in a number that one gets in your database. You just have a number in your database. Analysis timing is also critical. They also have found that you get elevated levels of lactate if it exceeds 5 minutes from the sample being taken to actually putting it in the analyzer machine. And then again, the arterial versus venous misidentification when you're actually taking the sample itself. So this was a lovely study by Lin and Beebe in 2007 that kind of shows both with pH on the, we'll go that side of the screen, that kind of just shows over time the kind of degradation of the pH as you see it from when the sample is taken versus the base excess as well. So you'll see a pretty steep incline at first and kind of plateaus out, but I thought it was a really good visual representation of timing mattering a lot for whether the pH you're getting in your database is actually reflective of the fetus itself. And then the biggest issue that I have with pH, and what I love a good conversation about, is the predictive value problem. So 75% of babies who have injuries had normal pH values. So that just goes to show you that while, yes, a low pH is very associated with poor outcomes, having a low pH is not necessary to have injury. And this goes back to all the talks during the workshop about pH is not the only thing, acidemia is not the only thing that causes injuries as well. Some of these babies may have been injured before the labor process, so there's such a complex issue in general. And then even seeing the absolute risk below 7.0 cutoff is only 2.95% as far as neurologic injury goes. So it just doesn't reliably predict HIE severity. when you're just looking at one number, and even if you kind of take in other things as well. And so I also just put the different thresholds that other people have used it for. Below 7 is often the kind of threshold that the neonatologists will use, or for kind of the therapeutic cooling as well. So there still are cutoffs and things that we use in clinical medicine to help do that, but you still have different levels that also confer risk. Should be cooling more babies versus not. That's a whole different lecture and conversation. Then kind of things that are going beyond standard cord pH. There is a newer kind of eucapnic pH, which is trying to take into consideration the kind of respiratory portion of things. They found that its predictive value had less false negatives than just using normal pH, so something that may be being used more in the future. Base excess over pH, should we be using that versus not? In our own studies at Stony Brook, we didn't find that using the base excess or the pH gave us any better predictability in our machine learning models, but just kind of considering that it might be a little bit better for showing like mild to moderate acidemia. And then this study was just recently published in 2025 that kind of looked at the predictions of different things like death, severe morbidity, and hospital death, IVHs, or moderate severe BPD, and looking at a combination of using pH and APGAR scores together. So again, should we combine things? How should we be doing things? And what other kind of outcomes should we be using for prediction and fetal well-being? And then kind of specifically why I wanted to kind of talk about this is kind of what I've talked to like my group a lot is this kind of trap that it's lovely to have a number and an objective thing to be able to use, but it might be a little bit of a trap as far as what we're getting when we're trying to predict stuff. So training on a flawed surrogate is what I kind of said, garbage in, garbage out. If all of these issues with what I just said about the validity of what this pH is reflecting, you're going to train your models on something that's not actually reflective of fetal well-being and or long-term outcomes. Label noise is systematic. So again, that delayed cord clamping, not knowing all these other variables of whether this number is a good number or not for what you are trying to look at. And then there's some issues between the respiratory versus metabolic blind spot as well. Some other kind of specific machine learning pitfalls. So extreme class imbalance is something that I know different methodologies can overcome, but you still have basically severe acidosis occurs in only, again, this is just from one study, but 0.26 to 1.3% of all deliveries. So the majority of your sample set is going to be either a normal pH or a normal baby. So how do we, if the model predicts poorly, it's oftentimes going to predict the right way because the right way is a normal baby the majority of times. Gestational age confounding, I kind of went into that a little bit, but kind of misclassifying post-term infants as acidotic and preterm infants as normal just because the pH along different gestational ages changes. So making sure that your models are taking into account gestational age issues. And then assumption that delivery pH reflects only the last 30 to 60 minutes. I think this was a big topic over the last 2 days. It really went into what does this reflect? What does the tracing reflect? Is this actually labor stuff? Is this pre-injury? Is it not? A lot of work in this space of using pHs and CTG uses the last 30 to 60 minutes of a tracing and correlating that with pH. However, as we've talked about this whole last 2 days, there are so many things that go into this. Is this chronic acidemia? Is this nothing to do with the labor process at all? And so how can we look at the evolution of the tracing and the fetal well-being over time to be able to actually say, yes, this fetus is well. Do I intervene? Do I not intervene? Because that's what part of what we're trying to do as well is let's not intervene when we don't have to. Let's keep going when we can and it's safe. So things, towards a better modeling system, designing kind of principles. I have no magic answer of what we should be using, how we should be using it, what composite scores to do. But I think that having composite outcomes, multimodal predictors, then having kind of some external validation in that. But cord pH basically, in my estimation, is a flawed surrogate for neonatal injury, but specifically fetal well-being as well. And machine learning models trained on cord gases alone risk being really technically proficient. However, is this clinically irrelevant, from the long term? So that is my talk, and thank you for listening to me.
Wonderful. Thank you for keeping so well within time. And we have a good time for discussions and questions, which I know are many. Anybody? Because I have a few, but I won't do it. I'll contain myself. Okay, then I'll go. Cassandra, no. Wait.
Come back, I'm coming back.
Wait. Look, thank you so much for insisting on bringing the topic back in. And we can have the next speaker start. I think it's you setting up, which also will be about pH. But I want to mention in the meantime as well that one thing I want to ask is about lactate, because you mentioned base deficit and pH. I assume you don't do lactate. Yeah, a lot of European countries do lactate, and it seems maybe there is a bit more of a thing there. But what I wanted to mention as well is that this is a topic that we've debated heavily from SPAM edition number 1. And, I had to learn through this forum so much, and I'm glad, that you brought it up still again as a reminder. And one thing I'll mention as well is that pH is extremely easy to predict actually in terms of low pH with decelerations and so on. The correlation is very, very good for what we are used to seeing. The problem then is that, obviously there's so many heterogeneous outcomes. So I'm sorry for rambling, but there isn't a real question, I think, beyond the lactate one. But it was more just extending how important that topic is and maybe inviting, stimulating the forum a bit.
Yes, while they set up. I'm not very familiar with pH and all the processes that go on in labor, so I'm curious if in any of these studies, when they kind of, you've given the range and sort of the normal kind of trends in terms of either cases with injured babies or not injured babies, are they taking the pH sort of multiple times, and are you kind of getting an average, or is it just a one-off?
Yeah, so before, historically, when they used to do fetal scalp pHs during labor, you had a lot more data to look at. There's also issues with fetal scalp pHs not actually correlating to cord pHs, but really these are, besides the ones that we're looking at like over time, most of the predictive pH papers are just using the umbilical cord pH at delivery. There are some articles that look and compare the delivery cord umbilical pH to, say, placental ones they get out of there, or even babies in the NICU who get samples, directly from there. So there's some stuff out there, but most of it is just delivery cord, and that's what people are getting.
Okay, interesting. Yep. Thank you.
I knew it, Susanna.
Thank you. Really, really a nice talk, and highlighting that we have been flawed for a long time with this pH, and so many times in research we just measure because it's easy, and then we get in this circle that doesn't garbage in, garbage out. So we have noticed for a long time that, for instance, babies with chorioamnionitis will do very unwell and actually have too good pH.
1,000%, exactly. You're like, that's not good.
We also know that babies with chronic hypoxia have a very normal pH and do very, very unwell. There are some things that, from a clinician perspective, are very important that, and I get this team here that to look at that data. So one of the things that I'm very keen to look at is from the cord pH to the neonatal pH.
Yes.
Because there's a trend there that clinically we understand babies that are born with a very low pH and very quickly recover, they are going to do very well.
Yes.
And if you are born with a low pH, then you can't ventilate because you have meconium aspiration or something, usually chorioamnionitis inflammation pathway, and then they just go down from there. So these double samples, for those that have those data, I think they will tell a very interesting story. And that's what I wanted to say. So thank you.
And I think it'd be really interesting to actually do something prospectively, because a lot of times your double samples are only coming from babies who are going to the NICU or going to another level of care where they're getting that second sample, versus kind of prospectively trying to get that in normal babies and then babies who need more care too. But I will.
Well, next talk is about pH as well, right? So you